everyone. Thank you so much for joining us. Good morning, good afternoon, good evening, based off of where you are. Welcome to the IACH for Pharmacists, our webinar today. My name is Kendall Shultes. I'm one of the stem cell transplant and cellular therapy pharmacists at the Nashville VA in Nashville, Tennessee. And today we have Dr. Tiba Sagheer, who is going to be talking with us. She's a clinical pharmacy specialist at Miami Cancer Institute. She practices in an outpatient clinic as part of a multidisciplinary team where she provides direct patient care and participates in clinical research and education. Her areas of interest include malignant hematology, blood and marrow transplantation, and cellular therapy. Tiba was the pharmacist who was a part of the development team for mobilization guidelines, and today she's going to be speaking to us on stem cell mobilization strategies in multiple myeloma. Thank you.
Thank you so much for that introduction. So as mentioned, I will be reviewing the stem cell mobilization strategies in multiple myeloma. The learning objectives for today's session include understanding the importance of stem cell mobilization in multiple myeloma, identifying the risk factors associated with poor mobilization, and comparing the current stem cell mobilization strategies, as well as evaluating the role and efficacy of Motixafortide in stem cell mobilization. So to start off, multiple myeloma is a malignant neoplasm of plasma cells that accumulate in the bone marrow, leading to bone destruction and marrow failure. It is most frequently diagnosed among people aged 65 to 74 years, and the median age of diagnosis being 69. The American Cancer Society has estimated about 35,000 new multiple myeloma cases and about 12,000 deaths in the United States in 2024. And multiple myeloma is the second most common hematologic malignancy, historically associated with median overall survival of 24 to 30 months. However, the development of high-dose chemotherapy, autologous stem cell transplantation, immunomodulatory drugs, proteasome inhibitors, as well as anti-CD38 monoclonal antibodies and other novel therapies have greatly expanded that therapeutic option for those patients. And currently, the median overall survival exceeds that of 45 to 82 months, with autologous stem cell transplantation playing a central role in the treatment paradigm. So knowing that autologous stem cell transplantation increases that depth of response, progression-free survival, and overall survival in multiple myeloma patients, it's important to be able to have adequate cells to be collected for that procedure. The recommendations for stem cell targets and doses, the minimum is 2 million CD34 cells per kilogram, and the recommended is anywhere from 3 to 5 million cells or higher for those patients needing to obtain 2 autologous stem cell transplants. So CD34 cell dose plays a role in engraftment as well as outcomes associated with transplant. We know that higher cells have shown to accelerate the hematologic reconstitution, shortening the platelet and neutrophil engraftment time, improving overall survival, and reducing hospitalization. And that's why the collection of those sufficient autologous stem cells relies on successful mobilization strategies from the bone marrow niche into the circulation. So the bone marrow niche pathways in hematopoietic stem cell mobilization is quite complex and unique. And there are some adhesion molecules that hold those hematopoietic stem cell and progenitor cells in the bone marrow. So we know that CXCR4 receptor on those hematopoietic stem cell and progenitor cells interact with chemokine SDF1, and that allows them to stay in the bone marrow. A disruption of this interaction can cause mobilization, and this can be achieved by medications such as GCSF, which is going to cause SDF1 downregulation and release of proteases, and Plerixafor and Motixafortide, which block that interaction between CXCR4 and SDF1. There are some factors associated with poor mobilization that can be patient and disease-related, treatment-related, or even just at the time of mobilization, some factors have been shown to impact that outcome. So patients of older age, those with extensive bone marrow involvement, as well as those that have been treated for more than 180 days prior to stem cell mobilization, prior exposure to radiotherapy involving those marrow-rich sites, multiple lines of therapy, and of course, exposure to some agents such as melphalan, fludarabine, platinum-containing regimens, alkylating agents, and lenalidomide and daratumumab, which we'll discuss a little bit more in detail today. Some other things at the time of mobilization that have been shown to be associated with poor mobilization include absolute monocyte count of less than 500 per microliter, platelet count of less than 150,000 per microliter, low steady state peripheral blood CD34 count, as well as low pre-apheresis peripheral blood CD34 cell counts, low day 1 apheresis yield, as well as history of mobilization failure. So if a patient has any of these, we know that they may have a poor mobilization. So what are the current hematopoietic stem cell mobilization strategies? We have cytokine mobilization alone, so using GCSF or GM-CSF, or we can add Plerixafor to that. So most commonly used filgrastim, which is the GCSF, but there are other biosimilars available. Or you can use that in combination with chemotherapy plus minus Plerixafor. Pegfilgrastim has been reported to be used with Plerixafor and also filgrastim plus Motixafortide. For today's discussion, I will be focusing on these two, and we'll be diving a little bit deeper into the filgrastim plus Motixafortide data. So here are the mobilization schedules with stem cell mobilizers. To orient you, the mobilization days are listed on the top. Apheresis typically starts on day 5 and may continue for up to 4 days. GCSF is administered starting with day 1, and that is given daily in the morning until the mobilization collection procedure is completed, and you may have the option to do that alone or plus either Plerixafor subcutaneous or Motixafortide subcutaneous injection. For Plerixafor, it can be given up to 4 doses, and that's typically given the evening prior to the first apheresis session, so given on day 4, 11 hours, or maybe even extended 15 to 17 hours, and Motixafortide is only given on days 4 and 6 if needed, depending on the apheresis collection yield that's obtained. So we'll talk a little bit about Plerixafor or Mozobil. It is an inhibitor of CXCR4 chemokine receptor that blocks the binding of it to the ligand SDF1, resulting in that mobilization of hematopoietic stem cell and progenitor cells from the bone marrow into the peripheral blood. It is approved currently in the United States by the Food and Drug Administration, or the FDA, in combination with GCSF to mobilize those stem cells for both patients with multiple myeloma and non-Hodgkin lymphoma. And the dose for that can be split based on the patient's weight. So as I mentioned previously, it's administered starting on day 4, and it can be given either as a flat dose of 20 milligrams for patients 83 kilograms or less, or can be a weight-based dose. And for those above the weight of 83 kilograms, can be given 0.24 milligram per kilo for a maximum of 40 milligrams per day. It is a subcutaneous injection that's given the day prior to apheresis. And it's important to note that there are some renal impairment dose adjustments that are necessary for those patients with a creatinine clearance of 50 or less mLs per minute. So the dose needs to be decreased by a third to 0.16 milligram per kilo with a maximum of 27 milligrams per day. There are some important things to mention here, which will help us compare and contrast the different agents. So for Plerixafor preparation and storage, it's available as a single vial injection. So there's no preparation that's needed, no compounding that needs to be done. And it can be stored at room temperature, but there are also excursions that are permitted, and there are no pre-medications needed prior to the dose. So we'll talk about the pivotal trial that brought this to market back in 2009 is when it was published. So this is the AMD 31001, 3102 study, which was a prospective phase 3 double-blind placebo-controlled multi-center trial that included 302 patients anywhere from 18 to 78 years of age with a confirmed diagnosis of multiple myeloma, good performance status, and adequate organ function proceeding to first autologous stem cell transplant in the first or the second CR/PR. This was a randomized 1-to-1 ratio for patients either being stratified to receive the G-CSF plus Plerixafor in the schedule discussed previously or G-CSF plus placebo. The primary endpoint was the proportion of patients collecting 6 million or more CD34 cells per kilogram with 2 apheresis sessions, and the secondary endpoints were achieving more than 2 or more, and 6 or more million cells per kilogram within 4 or less apheresis sessions. They also looked at the number of apheresis days required to reach 6 million or more cells. So again, this is the schedule that was done in the trial. So similar to what we had previously discussed, it's important to note in the trial, the injection was done 11 hours prior to the apheresis based on the label. So here are the results. I'll hone your attention to the first column. So the first column is the primary objective, which was the proportion of patients achieving 6 million or more CD34 cells in 2 or less apheresis sessions. As you can see, there was a statistically significant improvement in the collection of 71.6% compared to 34.4% in the placebo arm. These results were done by a central lab analysis. So that's also another thing to note. And when you look at the proportion of patients collecting greater than 6 million and less than 4 apheresis, that number increased to 75.7 compared to 51.3, and it was about 88.3 in those patients needing collecting 2 million or more CD34 cells in less than 4 apheresis sessions. It's important to note that the median number of apheresis days was significantly less in the patients who received Plerixafor at 1 day versus 4 days in the G-CSF plus placebo, and there was a statistically significant higher median number of CD34 cells collected in the Plerixafor arm at 10.96 compared to 6.18. The most common adverse events that were related to Plerixafor were gastrointestinal disorders, so nausea, diarrhea, vomiting, as well as injection site reactions, mostly erythema. And more recently, there was a publication looking at the long-term follow-up with Plerixafor, which showed no difference in overall survival or progression-free survival with addition of Plerixafor at that 5-year mark. So this is reassuring that data from 2009, and now we have more updated data showing that the use of Plerixafor does not impact overall survival, progression-free survival. So because the pivotal trial was conducted prior to the daratumumab, as well as the anti-CD38 monoclonal antibodies and quadruplet induction therapy era, it makes it a little bit more challenging for us to translate those data into what we currently do, especially with more data moving quadruplet therapies in the frontline setting for those newly diagnosed multiple myeloma patients. So there was a recent post hoc analysis that was done to examine the effect of daratumumab and lenalidomide containing quadruplet induction therapies on stem cell mobilization and yields, and to evaluate the engraftment kinetics and explore potential effects on stem cell recovery in those newly diagnosed multiple myeloma patients. That data was pulled from the MASTER trial and the Griffin trial. So the MASTER trial included four 28-day cycles in single arms. So patients received Dara KRD, so that's daratumumab plus carfilzomib, lenalidomide, and dexamethasone. And the Griffin trial had 2 arms that were the treatment was given in 4 21 cycles, randomized to either RVD, which is lenalidomide, bortezomib, and dexamethasone, or daratumumab added to RVD. This is the schema of the patients in both arms. So you can see the upfront Plerixafor strategy that included basically patients that were planned to receive Plerixafor regardless of their blood CD34 count on day 4. The strategy was the general approach for patients with high risk for mobilization failure who were unlikely to collect sufficient stem cells for transplantation, while the rescue Plerixafor strategy included initiating cytokine mobilization only, followed by the identification of those patients that would need a rescue, or what we would refer to as just-in-time Plerixafor dosing, for those patients that had suboptimal pre-apheresis blood CD34 counts, which would allow for a salvage mobilization attempt. By using that, the rescue strategy, some patients had sufficient collection yields, while others were able to only collect with the GCSF alone. So among those patients who underwent mobilization, in the DARA-KRD, 98% of those patients were able to proceed to autologous stem cell transplant with a cell dose of 3.2 million, while the DARA-RVD in the Griffin trial, 99% of those patients were able to present to autologous stem cell transplantation with a slightly higher number of cells at 4.2 million. And the RVD arm, the 98% of patients were able to proceed with autologous stem cell transplantation with even a higher number at 4.8 million cells. Patients who collected with GCSF alone in the first mobilization cycle, there were 100% in the DARA-KRD, 98% in the DARA-RVD, and 96% in those with RVD alone. So for patients who did not meet those center-specific minimally required CD34 cell yield, which was listed at 2 million, in the master trial, there were 7% of patients who did not achieve that minimum, and 5 of them were in the upfront Plerixafor, while 3 of them were in the rescue Plerixafor arm. And the Griffin trial, it was only 2%, while with the DARA-RVD versus the RVD alone was at 6%. So again, with the mobilization failure rates being anywhere from 2 to 7, it's quite low. So the conclusion was that 4 cycles of daratumumab and lenalidomide-based quadruplet induction therapy had minimal impact on that stem cell mobilization, and allowed predictable stem cell harvesting and engraftment in all patients who underwent autologous stem cell transplant. So prior to Plerixafor becoming generic, it was a brand only, and it was a costly medication. So it was not feasible for institutions to use it upfront for all patients, just from a cost standpoint. So there were quite a bit of studies done to look at what's the best approach to use in order for us to give Plerixafor. And they investigated the different peripheral CD34 thresholds on day 4 prior to beginning apheresis. So this was a single center retrospective analysis that included patients with multiple myeloma and other plasma cell dyscrasias who underwent mobilization from January 2012 to December 2016. The primary endpoint was looking at the changes in mean Plerixafor utilization and apheresis days, as well as assessment of impact of overall mobilization costs. And the secondary outcome or endpoint was looking at the impact of lenalidomide on those mobilizations. So here you can see it was found that on the left-hand side, the split of the peripheral blood CD34 thresholds to initiate Plerixafor was split into less than 15, less than 20, and less than 40. And you can see that the mean Plerixafor dose per mobilization goes from 1.32 to 1.65 to 1.74, while the mean apheresis days gradually go down, 2.15, 2.17, and 1.89. When we look at the cost that was associated with each different bucket, you can see in the less than 15 cells per microliter and the less than 40 cells per microliter are quite similar in terms of cost. And this is because you're also taking into account the cost of the apheresis day itself. So therefore, the combined cost of Plerixafor and apheresis procedures at the threshold of 40 cells per microliter is close to that. And you're also saving 26 apheresis days per 100 patients. So this cutoff was implemented at our center, and I think most centers have also looked at this to help make the changes. And now with Plerixafor being generic, so this formula may change and the price difference may be even more drastic. And now the impact of lenalidomide on the use of mobilization in this particular study, they looked at patients who received lenalidomide-based induction had a median day of peripheral CD34 counts lower of at 9.38 versus 10.47. But there was no significant decrease associated with the recipients of 6 cycles or more than 6 cycles. However, the median day, 5 peripheral CD34, was similar irrespective of that lenalidomide. And there was no appreciable difference in the Plerixafor or apheresis between those patients that received 6 cycles of lenalidomide versus those of no lenalidomide at all. However, those patients that received more than 6 cycles of lenalidomide required an average of 2.1 Plerixafor doses and 2.34 leukapheresis sessions, which is significantly higher compared with other cohorts. And then also there was no difference in the total stem cell yield or neutrophil engraftment among all of 3 cohorts. So patients who received 6 or more cycles, lenalidomide demonstrated impaired mobilization and required more apheresis session and greater Plerixafor use to achieve that target stem cell yield. Another study that was done a year after was also a retrospective analysis from 2012 to 2015 and investigated the prior exposure of lenalidomide, and they found that exposure of lenalidomide did not have a statistically significant impact on the absolute number of CD34 cells that were selected or collected, or on the duration of the collection based on the multivariate regression analysis. However, there was a linear multivariate analysis that showed a trend towards decreasing collection yield with increasing cycles of lenalidomide. So the data is mixed with whether there's a specific number of cycles and whether the exposure really impacts the collection or not. At our center currently, we try to recommend referral to autologous mobilization prior to 6 cycles of lenalidomide, especially that our center typically uses quadruplet therapy much more heavily. And this is a sample of mobilization algorithm that was developed by my group based on the data that was presented. So again, patients above the threshold of 40 do not receive any Plerixafor. Those between 5 and 40 do receive Plerixafor, and less than 5 we omit Plerixafor, and that's based on other data that was published showing that only 71% of patients who had a peripheral CD34 count of less than 5 on day 4 did not mobilize the adequate number of cells. So now we'll switch gears and talk about Motixafortide or Efficacy. This is another stem cell mobilizing agent that selectively inhibits CXCR4 by binding to the SDF1 alpha CXCL12, resulting in that mobilization of hematopoietic stem cells. It is also approved in combination with GCSF to mobilize stem cells for the purpose of autologous stem cell transplants. However, it's only FDA approved for multiple myeloma, unlike Plerixafor, which also has an approval for non-Hodgkin lymphoma. The dose is to initiate Motixafortide after filgrastim has been administered for 4 days, and it's at 1.25 milligram per kilo by subcutaneous injection, done anytime 10 to 14 hours prior to the initiation of apheresis. If a second dose is needed, that dose is being given prior to the 3rd apheresis day. So some preparation and storage things that are important and make this different from Plerixafor is that this product needs to be prepared, and prior to preparation, it has to be removed from the refrigerator to allow it to reach room temperature for at least 30 minutes. And it needs to also be reconstituted, which can take time. So unlike Plerixafor, where you don't have to have that 30-minute wait and you can just take it, drop the amount of drug, here you need to wait for 30 minutes. You need to also mix it and reconstitute it prior to administering it to the patient. And another thing to note is that each injection volume should not exceed 2 mLs. So basically, any patient above the weight of 58.4 kilograms would need to be poked 2 times because you cannot exceed the maximum number of 2 mLs. And another thing to note is after that product has been reconstituted, it needs to be stored either in refrigerated or room temperature for a maximum of 24 hours, and it needs to be protected from light. So if you have a patient that you are considering giving this product to, I would probably wait to mix it until you know that they for sure will need to have this product administered. In terms of the dose calculation, so the formula on the top kind of shows what volume needs to be administered, and then on the bottom, the table shows you, based on the patient's weight and cutoff, the number of vials that you would need and the number of injections that the patient would have to be given. So every vial delivers 1.7 mLs, which is 62 milligrams. And depending on the patient's weight, you would need to use basically anyone over 49.6 kilograms, you would have to open up 2 vials to make up the dose for them. And that would also be resulting in multiple pokes because of that 2 ml maximum. These weights can also be rounded to the nearest 50, so 49 becoming 50, 99 becoming 100, etc. Now, in terms of administration, Motixafortide should be administered only in a setting where personnel and therapies are immediately available to treat an anaphylactic or systemic reaction, and patients must be monitored for 1 hour after administration. So this is important for logistical considerations, because if your center is only open for a certain time of hours and you were aiming to give that Motixafortide or Plerixafor at the end of the day, you may need to shift it 1 hour up to allow for that 1 hour observation time. It also requires pre-medications to be given 30 to 60 minutes prior to the Motixafortide injection. So the histamine or H1 antagonist, H2, and leukotriene receptor antagonists are mandatory, with the addition of an analgesic such as acetaminophen is also recommended. And the administration of it is a slow subcutaneous injection, so about over 2 minutes in either the abdomen, backside of the upper arm, or the thighs. And if there are more than 2 injections needed, you need to separate those injection sites by 2 centimeters. So now that we talked about those properties or preparation pearls, the pharmacodynamic properties of Motixafortide is what makes it different from Plerixafor and makes it stand out. So it's a potent antagonist of CXCR4, and it has an IC50 of 0.42 to 4.5 nanometers. So that basically means that the smaller, the lower the number in nanomolars, is the more potent the inhibitor is. You also have a binding affinity of 7.9 and a dissociation rate that's very, very small. So basically that means that it resides at the receptor for a longer time, and it allows for that longer receptor occupancy of greater than 72 hours. So despite it having a shorter half-life, it sits on that receptor for a long period of time. Now, the trial that brought this to market was the Genesis trial, which was a prospective phase 3 double-blind, placebo-controlled, multi-center study. The inclusion criteria are listed here, and it was randomized 2-to-1, either to G-CSF plus Motixafortide or G-CSF plus placebo. The objective was assessing the superiority of Motixafortide plus G-CSF over placebo plus G-CSF to mobilize stem cells in multiple myeloma patients. Some exclusion criteria that I felt were important to note is that patients who have undergone prior transplant or failed mobilization attempts were excluded. Those that received more than 6 cycles of lenalidomide or thalidomide, more than 8 cycles of an alkylating agent, 6 cycles of melphalan or radioimmunotherapy, or had prior venetoclax were excluded from the trial. And the primary endpoints are quite similar to what we saw with the Plerixafor trial. So you're looking at mobilizing 6 million or more cells in up to 2 apheresis sessions after 1 single Motixafortide injection. And then the secondary endpoints, either 2 million in 1 apheresis session or 6 million or more in 1 apheresis session. There were additional secondary endpoints looking at time to neutrophil and platelet engraftment, graft durability, overall survival, and progression-free survival, with an exploratory endpoint of CD34 cell concentration in the peripheral blood. This is the schedule that we looked over again. So again, it's given 2 times on day 4, and if needed, again on day 6, all-day apheresis. The baseline characteristics are balanced between the 2 groups, so they're listed here for you. It's important to note that there were no patients in the Motixafortide arm that had received a prior anti-CD38 monoclonal antibody, so that may help aid in the decision of when to use it. And the results were read by 2 different laboratories, a local laboratory as well as a central laboratory for assessment. So the local laboratory included the determination that patients met the collection goal as for the primary endpoint and the number of cells that were infused. So as you can see, there was a statistically significantly higher collection rate of cells for the primary endpoint at 92.5 compared to 26.2 in the placebo arm versus 88.8 for achieving greater than 6 million in one apheresis session compared to 9.5, and then greater than 2 million, 96.3 compared to 64.3. The median number of CD34 cells that were mobilized in one apheresis day with Motixafortide was also higher at 10.8 million compared to 2.2 million for the placebo arm. This graph here shows you the incremental increase from day 1 of apheresis to day 2 to day 3. It's important to note that no patients in the Motixafortide arm needed to go for a 4th day of apheresis. And these are the results for the central laboratory assessment, which are unfortunately lower than what we saw with the local laboratory. This can be due to several factors. The trial mentions that the central laboratory assessment was done several days after the collection of those stem cells. So could the cell viability be an issue? It is unknown, but you can see here that the primary endpoint was 67.5 compared to what we had seen earlier, which was in the 90s. And that percentage also decreases for achieving greater than 6 million in one apheresis session, and so on. Now, the time to neutrophil and platelet engraftment, graft durability following transplantation, and overall survival and progression-free survival were not different between the 2 groups. However, it's important to note that the baseline peripheral CD34 cells before G-CSF administration and between the Motixafortide and the placebo arm were similar at baseline, but you can see that there was a jump in the Motixafortide going from 15.8 to 116 on that day 5. So it definitely led to a robust increase in the peripheral CD34 cells compared to the placebo, which you can see going from 12 to 19. Now, other things the study looked at was the immunophenotyping of those stem cells. So immunophenotyping and transcriptionally distinct CD34 subsets ranging from those primitive hematopoietic stem cells capable of, long-term self-renewal and multi-lineage potential to relatively differentiated lineages committed progenitors. Compared with placebo plus G-CSF, Motixafortide had significantly increased percentages of those common lymphoid progenitors, natural killer precursors, and basophil precursors. And compared with the Plerixafor, Motixafortide arm increased percentages of those multipotent progenitors and common myeloid progenitors, as well as the natural killer cells precursors and basophil precursors with fewer lymphomyeloid primed progenitors. So taking together these data suggests that Motixafortide induced pan-mobilization of multiple hematopoietic stem cell and progenitor cell subsets capable of that broad multi-lineage hematopoietic reconstitution with notable increases in those primitive cells. However, with all that being said, the study was not powered to detect any difference in those, and this is just really hypothesis generating, so we don't know how those variabilities in the immunophenotyping can actually impact transplant outcomes. In terms of the safety and toxicity that was seen with the Genesis trial, so we see a lot more local injection site reactions and systemic injection reactions compared to the placebo arm, as shown here. However, it's important to note that the patients who received at least one dose of Motixafortide, 14 received triple pre-medication as recommended, and the rest did not receive that triple pre-medication. They either received no medications or just one medication. And this is because initially the trial was not designed to provide those triple medications. It was only with one pre-medication, and later it was amended. Some other serious adverse reactions that occurred in about 5% of patients included vomiting, injection site reaction, hypersensitivity, injection site cellulitis, hypokalemia, and hypoxia. So because the initial protocol was amended later on to include those combination pre-medications, there was an ASH abstract presented in 2023 that reported the safety findings in a cohort of patients who received single drug pre-medication with an H1 antihistamine prior to the protocol amendment compared to those that had the optimized medications. And as you can see here, following the implementation of the protocol amendment, the frequency and the severity of hypersensitivity and injection site reactions associated with Motixafortide was drastically decreased. So maybe in the real world, we may not see as many hypersensitivity reactions if those pre-medications are optimized. So some warnings and precautions that are in the label include anaphylactic shock and hypersensitivity reaction, again, across all patients that received Motixafortide, 0.7% actually had an anaphylactic shock. Usually the time is anywhere from 5 to 30 minutes after the drug administration, which makes sense why patients need to receive this therapy in a facility where they can be monitored for up to 1 hour and be promptly managed. Also, patients that are receiving concomitant negative chronotropic drugs, so for example, beta blockers, may be at higher risk for hypotension in cases of hypersensitivity reactions. So as pharmacists, when appropriate, of course, recommending an alternative therapy for that drug. Other things includes injection site reactions, tumor cell mobilization, leukocytosis, and embryo-fetal toxicity, which is kind of similar to what we typically have seen with Plerixafor. So this is the schema of the current hematopoietic stem cell strategies. First line mobilization. On the left side, you can see cytokine mobilization alone, which is least costly with highest failure rate. And then you can see G-CSF plus minus Plerixafor being somewhere in the middle because we know that it's effective. And now with the cost adjustments, it has really decreased the financial toxicity. And then remobilization options, I listed chemotherapy plus minus Plerixafor and G-CSF because it's not typically used as front line for mobilization unless the patient has disease burden or needs it for remobilization. So this kind of brings the question of where does Motixafortide come into place? Where are we going to put this drug? So in the Genesis trial, there was a correlative study that was done, which looked at demographically similar patient cohort undergoing mobilization with Plerixafor plus G-CSF that were enrolled in that single site parallel tissue banking. And the intervention was either what's in the Genesis trial, Motixafortide versus placebo arm versus the G-CSF Plerixafor. So again, this was not a head-to-head study. It's more of a correlative study. Looking at the baseline characteristics between all three different groups. So again, the Genesis trial groups that we had previously looked at, and then on the very far right, it's the correlative study cohort. They are well-balanced and even. When we look at the efficacy results, you can see the prospective parallel correlative study, which included Plerixafor plus G-CSF for those patients collecting greater than or equal to 6 million cells in 2 apheresis session, was at 78.6, which is kind of similar or comparable to what we saw in the pivotal trial of Plerixafor in 2009 at 71.6. And then These numbers, when you compare them, so again, these were done by the local lab, but when you compare the numbers that were done by the central lab, the numbers between Motixafortide and Plerixafor are kind of comparable, but again, the study was not designed or powered to detect the difference in these arms. So always take caution when looking at those correlative studies or cross-trial comparisons. So really the answer is, the data gives us an idea, but the study wasn't designed to detect or compare those, so it's hard for us to draw conclusions. And in terms of time to neutrophil and platelet engraftments, they were the same across all three groups. So let's look at extended mobilization. Could Motixafortide open up the window since it has a longer binding to the site? Could it be, taking place of Plerixafor? So we know with Plerixafor, it was FDA approved to be given about 11 hours prior to apheresis, but there was data that showed extended efficacy, or that extending that time between the injection of Plerixafor and the start of the apheresis session. So apheresis initiated between 17 to 18 hours versus 10 to 12 hours post Plerixafor did not significantly comprise the mobilization collection goal. However, the ideal time to initiate apheresis may be anywhere in that 15-hour post-Plerixafor for good mobilizers, which included patients that had received Lenalidomide in the past, and about 8 hours in those patients with that are considered poor mobilizers, such as those with diabetes or salvage chemotherapy. It's also important to note that this study included patients that had multiple myeloma and non-Hodgkin lymphoma. Now, with the Motixafortide, we know that it's approved to be given 10 to 14 hours prior to the apheresis session. And in the Genesis trial, apheresis was performed beyond 14 hours in approximately half of those patients, and that there's data showing that there's no correlation between the timing of the apheresis and the cell yield in patients who collected at the 10 to 14 hours versus 14 to 16 hours. And there's also data in healthy volunteers showing that CD34 cells reached a maximum at the 16-hour mark, followed by that slight decline, but it remained elevated for more than 24 hours. So the reason why this matters is because for those centers that have limited operating hours, knowing when to give, what's the latest time to give Plerixafor or Motixafortide can impact those operating hours. So if you're only open until 5 p.m., giving Motixafortide or Plerixafor at 3 p.m. and having that leeway of time to be able to start your apheresis session the following day, not super early, can definitely be useful. So what about chemomobilization? So it is an option for peripheral stem cell mobilization, especially again for those patients with active disease that also need anti-tumor activity. The issue with chemomobilization is that it takes a longer time. It can be, until 11 to 13 days, and it requires a greater resource utilization because you're having this patient come in every day for CBCs, and you're having them coming for injections, etc. So it's a lengthier process, but it's also associated with hematologic toxicities and also infections. So you're seeing neutropenias, you're seeing febrile neutropenias, possibly hospital admissions. So mobilization was associated with 30% more complications compared to mobilization with G-CSF plus minus Plerixafor, which included those neutropenic fevers, emergency department visits, hospitalizations, as well as increased costs. So that kind of puts things into perspective, but also we don't have a standard of that peripheral blood CD34 count to achieve prior to connecting the patient to apheresis. So unlike what we have seen with Plerixafor, we don't have that guidance with chemomobilization. And also, when do you start checking for peripheral CD34s is still also up in the air. So there's some data showing you want to wait until count recovery with a white blood cell count of greater than 4, or you want to wait until day plus 12. Again, depending on the institution, there are different cutoffs that can be used. So some considerations that we've covered, the 3 different big approaches that you can consider for mobilization, things to look into our financial toxicity. So how much will this cost the patient, the institution, resource utilization. So how many apheresis rooms or chairs do you have? Can you risk that maybe or maybe not you're going to hook up the patient to the machine on that day? Pre-medications and the chair time that's going to be needed and the availability. So if you're giving pre-medications, you're putting the patient in that chair an hour earlier, which can be utilized for another patient for something else. Patient comfort, so one injection versus multiple injections, distance from the apheresis center, transportation support, and caregiver support. So again, if somebody lives very far, it may not be a good idea for them to do chemomobilization where they're coming multiple times, and you may want to use something that has been shown to collect stem cells in one apheresis session, and then also monitoring time post-dose. And from the financial toxicity, here are some pricings or costs. So the apheresis procedure and cryopreservation can be approximately $13,000 per apheresis session. So when you're looking at the medication cost, it's also important to look at the apheresis sessions, because if you're using a lower cost medication but having to bring the patient back multiple times, you're still using those resources and leading to financial toxicity. So a quick comparison between the two drugs. So that we currently have to help us guide where Motixafortide is going to fall into place. So we have pre-medications are required with Motixafortide, but not with Plerixafor. You need some post-injection monitoring. In terms of cost, Plerixafor is now available as generic, so it may be less costly compared to the brand-only Motixafortide, requiring reconstitution. So again, resource utilization from the pharmacy standpoint, you need to do that with Motixafortide, but not really with Plerixafor. Renal dose adjustment, so that is required for the Plerixafor. And then some of those side effects, so GI and injection site reactions versus injection site reactions and systemic injection reactions with Motixafortide. And long-term follow-up data. So we have 5-year follow-up data with Plerixafor versus Motixafortide. It's still new. And data with anti-CD38 monoclonal antibody containing inductions is available with Plerixafor, and that's still not available with Motixafortide. The frequency, again, for injections up to 4 for Plerixafor versus 2 with Motixafortide, and then the maximum injection volume can be also a limitation for Motixafortide because of that 2 ml limit. So we're going to look again at the schema that we had. So where I felt that we could have Motixafortide plus Plerixafor be is somewhere either in the first-line mobilization strategies or as a remobilization agent. I think for first-line mobilization strategy, it can be reserved for those patients who are unable to travel to the cancer center or may need a higher stem cell yield. So again, you maybe want to collect them in 1 or 2 apheresis sessions versus going to 3 or 4. And it can also be an approach that you can consider for remobilizing option, even though in the Genesis trial, patients who have failed prior mobilizations were excluded. If a patient fails G-CSF plus Plerixafor, your next options are either chemotherapy-based remobilization versus Motixafortide. So that can be a discussion between the medical team and the patient, as well as, of course, being able to obtain insurance authorization and coverage for this drug. So maybe instead of spending 13 days providing therapy and injections for chemomobilization, you can explore the option of Motixafortide. But again, there is no data currently showing that after failure of Plerixafor, you can use Motixafortide. It's just kind of where our institution currently wants to take it to. So in summary, we know that there's no head-to-head data comparing Plerixafor versus Motixafortide, and the choice between these agents should be tailored per patient and institution while taking into consideration those risk factors for poor mobilization and socioeconomic factors. And there is data with Plerixafor and anti-CD38 monoclonal antibody induction therapies versus none at this point with Motixafortide. So I would be cautious with using it for those patients with upfront quadruplet therapies. And in the Genesis trial, there was immunophenotypic and transcriptional heterogeneity that was seen in the CD34 hematopoietic stem cell and progenitor cells mobilized across those different regimens. However, the clinical implication remains unclear. So we really can't take those different subsets and say that one drug is better than the other because we don't know how it translates. And mobilization strategy should be tailored per patient case, and costs associated with autologous stem cell transplants do increase with multiple mobilization attempts and apheresis session. So it's important to pick the appropriate drugs upfront in order for you to minimize those apheresis sessions and costs associated with them. And with that, it concludes my presentation, and I would be happy to take any questions if we have any in the chat.
Thank you so much. That was wonderful. I'm not seeing any questions right now, but we can give it a minute. I guess my one question for you would be, have you seen any reactions to the Motixafortide personally?
That's a great question. So I personally have not used this drug yet. We just took it to formulary this month to be added. So we are going to be reserving it for patients who do fail mobilization with Plerixafor. But personally, I have not experienced it or given it to a patient at our facility just yet.
No, we have not. I think it sounds
Mhm.
like we're a little bit behind you in kind of working from a formulary perspective
Yeah,
and figuring out how we'll use it too.
yeah. And I think it's interesting because the Genesis trial lumps those patients that did not receive any pre-medications. And the ASH abstract that was published last year shows there was a decrease. So I would be very curious to know how would this play with all patients who had received optimal pre-medications in reducing those rates.
Yeah, that's interesting. Are you thinking that you will still be doing it? I guess, what is your practice right now? Do you do probably like a 12-hour window pre-apheresis? Is that what you're thinking?
For when to
Wh-
administer,
When to administer? Hmm.
we're actually doing greater than 12 hours. So we typically administer around 5 p.m. and our
Okay.
center is 7 to 7, so 5 to 6, and then we would bring the patient in anywhere from 7 a.m. to 8 and start them there. And I think with that 14-hour gap, it would, if you were to give it at 5 or 6, you would still be able to hook up the patient to the machine.
Hmm. Yeah.
But in all honesty, the day after, so day 6, you're still hooking up the patient on the machine without administering. So because of that long binding activity
Hmm.
drug.
Hmm.
Yeah,
It's really interesting.
it is.
One of the questions that I'm seeing, we've got a couple now. Um, Do you think Motixa will be based on day 4 peripheral blood CD34 count?
That's an excellent question. So I actually don't know if there will be data because right now with Plerixafor, we limit, at least at our institution, we don't administer Plerixafor to patients with a CD34 cell less than 5 on day 4 because of that data showing that they are most likely unable to achieve. But when you look at and I think I can go back and show it. When you look at the graph that was published right here. So when you see this right here, it's quite heterogeneous on day 4 in terms of what was the peripheral blood CD34 counts, and I could see some where it was quite low. So it gives me an idea that probably patients were, received Motixafortide regardless of what their peripheral CD34 count and still achieved that robust, but you can still see some people on day 5 where it was still lingering quite low. And the division of which patients that are here were on day 4, I don't have that data, and I have actually requested it to see if that would be a niche for us to use. And I think the other part of the question was, would you use it? Would you use those cutoffs like we did with Plerixafor? I would not, because if I'm using it as remobilizing agent, you've already failed, so you want to just add it on regardless. So it would be kind of a comparison between Motixafortide GCSF versus chemotherapy Plerixafor GCSF. So I would probably add it on, preemptively, just like what they did in the Genesis trial until there is more data available. I hope that answers the question.
I think so. One other one that came across was quadruplet therapy is the gold standard now. Should we wait for more data before using it with anti-CD38 agents?
That's also another excellent question. Personally, I would say yes. So I would try not to use it just because with Plerixafor, we have that data now from the Master and the Griffin trial, but with the Motixafortide, we still don't have that data. So I would try not to use something that does not have data just yet.
That's all the that I see coming across. There's one about accessing slides that we can discuss as well. But thank you so much. This was wonderful. I don't see any other ones come across. That's it. And her email's there as well.
Yeah,
So,
my email's right there in case you have any other questions.
oh, one other one. Was there
Let's
any indication that we would see the use of Motoxa beyond multiple myeloma?
Yes, so that's actually an excellent question. There is some groups looking at this in the non-Hodgkin lymphoma, but also more recently, Motixafortide contracted with St. Jude's Children's to use Motixafortide to mobilize for the gene therapy with sickle cell. So I think that's a really nice niche that they're looking for. I think it's still quite immature from the data standpoint, but it was a very recent contracting that was done to be utilized as part of the sickle cell trials.
I think that's it. Great. Thank you so much. Appreciate it. We'll see you at the next one.
Wonderful. Thank you all.
Thank you very much.